Good morning or good afternoon, everyone, and welcome to Genome Webinars. I'm Julia Caro, Managing Editor at GenomeWeb, and I'll be your moderator today. The title of today's webinar is Review of Guidelines for Interpreting Somatic Hypermutation Status in Chronic Lymphocytic Leukemia in the Era of High-Throughput Sequencing. This webinar is sponsored by InVivoScribe. Our speaker today is Dr. Siby Sebastian, Professor of Pathology and Director of the Clinical Molecular Diagnostic Laboratory, as well as Associate Director in the Division of Molecular Pathology at Duke University Health System. You may type in a question at any time during the webinar, which you can do through the Q&A panel, which appears on the right side of the webinar presentation. We will ask our speaker your questions after his presentation has concluded. Also, if you look at the bottom tray of your window, you will find a series of widgets that can enhance your webinar experience. So with that, let me turn it over to Dr. Sebastian. Please go ahead.
Thank you, Julia. Hello, everyone. Thanks for joining this webinar. So I have a few disclosures to make. I receive a honorarium for this presentation from InVivoScribe, and my lab use reagents supplied by InVivoScribe for developing many lab-developed tests for different clinical testing, and I have no other conflicts. So we have a few learning objectives for this presentation. First, to review and discuss the clinical significance of somatic hypermutation status assessment in chronic lymphocytic leukemia. Also, review and discuss some current guidelines that will help to evaluating, interpreting, and reporting somatic hypermutation status in CLL. And I also would go through some of our experience with clinical testing of SHM analysis in CLL. So as many of you are very familiar with, what is a CLL, but I'm just going to run through some basic so that we can just have some good understanding. As we all know, CLL is one of the most common leukemia in Western countries. It represents roughly 30 to 40% of total leukemia diagnosed. And age-adjusted incidence in the US is roughly 1 in 100,000. And almost more than 15,000 newly diagnosed cases every year. And then, unfortunately, there's 4,500 deaths happen every year. And one of the hallmark of CLL is the median age at the diagnosis is 72 years. That's why CLL is often termed as a disease of the aging. And also another interesting observation is that more males than female in this patient cohort. So as you've seen, the CLL incidence rate rises with age. And even though the more detection is happening with the aging population, with the changes in the demography, especially longevity is increasing and other factors, we are going to see more and more CLL patients. And in addition, there's a lot of young patients have been identified with the early stage of CLL with minimal or no symptoms, but with during their annual physical or other situations. Also, the majority of patients actually are monitored with the watch and wait approach until a balance of risk and benefits can be assessed, and then to decide whether there is a treatment initiation is needed. And overall survival of the patients with the CLL is roughly for 5 years, range from 20% among very high-risk patients with the 90% or less aggressive. That's kind of a good situation. And some of the clinical features. So most patients present with an incidental finding of lymphocytosis or lymphadenopathy or organomegaly. And then bone marrow involvement can lead to anemia and thrombocytopenia. And majority of the patients are actually asymptomatic at diagnosis. But some patients with the constitutional symptoms with unexplained fever or weight loss for less than 10% in the last 6 months or so, night sweats, extra. And one of the, so we will see more while getting into the presentation, the CLL is a highly, highly variable clinical course. And some with the rapid progression with the fatal outcome to a relatively very indolent behavior for years. So clonal proliferation and accumulation of mature, typically CD5 positive B cell within the blood, marrow, or lymph nodes, or even spleen, is the identification of CLL. And these clonal mature B cells within lymph nodes or extranodal tissues without a peripheral blood lymphocytosis is called as SLL. And if you look at the genomic, there's a lot of studies have been came out lately, as you can imagine, with all the genomic testing become very common that help us to identify a genomic landscape of the CLL. And most of the patients present with a deletion, chromosomal abnormalities, large amount of chromosomal abnormalities, mainly deletion 13q, deletion 11q, and trisomy 12. And there is additional mutations may, along with these large chromosomal changes, make the disease more aggressive. So if you go through a little more genetic landscape of the CLL, again, more than 85% of the CLL patients carry a chromosomal abnormality. As you can see here, there's 55% also patients has been shown with the 13q140 deletion, and then 25% or so with the deletion 12, especially chemotherapy-naive patients with advanced disease stages, and 10% of patients with early stage disease. This is mostly associated with the ATM gene alterations. And trisomy 12 is observed in 10 to 20% of the patients. And deletion 17 is found in 5 to 8% of chemotherapy naive patients. So 17 deletion is almost always include 17p13, where actually the tumor suppressor gene TP53 is located. That is actually the causative of the etiology of the genetic change. And mutations in TP53 also found in 4 to 37% of CLL patients, and overall with a very poor prognosis. And patients carrying deletion 11q typically show some clinical characteristics like bulky lymphadenopathy, rapid progression, and reduced overall survival. This is again, ATM gene is in this etiology. And in addition, some of the poor prognostic features of deletion Q actually can be, fortunately, overcome by some of the new chemo immunotherapy treatment. That's good news. And obviously, with all the whole exome sequencing data from a lot of from CLL patients, reveal a large number of recurrent mutations. And almost 44 different genes. Mutation has been characterized in 44 genes, 11 recurrent somatic copy number changes. So some of the major gene involved with this mutation is shown here, especially the NOTCH1, TP53, ATM, SF3B1. They all play a very important role for prognostication, also for treatment decisions. And lately, the last few decades, there's a tremendous progress has been made regarding treatment options for CLL patients, especially chemoimmunotherapy, fludarabine, cyclophosphamide, and rituximab, CTI. And in other combination with other new generation treatments. And most importantly, more recently, there's a specific inhibitors, highly effective inhibitors, interrupting important pathways for CLL. Cell survival has been approved, ibrutinib and idenib and venetoclax. So what's happening last couple of years, few years, if you will, this inhibitor, the specific targeted treatment actually to replace some of the first line and second line indication for normally used for chemo immunotherapy. So just like many other malignant somatic based malignant processes as solid tumors or especially for lymphoma leukemia, most of the management decisions are based on genetic features of the disease itself. And obviously, there's a lot of patient factors play into CLL because of the average median age of the patients is with a lot of comorbidities, which can be a key factor deciding the best management approach. But again, the two major features of the disease management is presence of the P53 mutation or 17p deletion, and also the mutational state of the IGH variable region that we will go through a little more detail in the coming slides. So where is the story started with the somatic hypermutation? In 1999, two groups independently identified the clonotypic IGHV gene and its mutation status is an indicator of risk stratification. And if it is mutated, it means more than 2% of the sequences are in difference with the germline sequence. It is more of an indolent disease course, versus if the patient has an unmutated status, the disease progress faster and have shorter overall survival. This was a landmark study that actually opened up a lot of further studies and treatment options and prognostications. So what is the significance of somatic hypermutation status in CLL? So a couple of few interesting observations. The mutational status of this IGHV gene in this patient is relatively stable. And then roughly 60% of also patients at diagnosis identified with a mutated status. And rest, the unmutated CLL is actually characterized by high-risk genetic lesion that is actually contributing to the more progressive disease. And also rendering disease to a more clonal evolution. And also association with a shorter time to first treatment and overall unfavorable survival. 30% of the patients carrying also a stereotyped B-cell receptors, which are found to have a distinct clinical outcome, particularly in specific subtypes. This is a kind of relatively a new area of studies in CLL, and I would go through a couple of those during the presentation. But this is something is really coming into a clinical management decisions very soon. And also occasionally surrogate markers like SAP70, CD38, and other markers can be used, but used to decide. But overall, still IGH hypermutation determination is highly favored. So again, as we have seen, the SHM status has a strong predictive value for the response to the treatment, and unmutated CLL displays shorter progression-free survival after even chemo immunotherapy. And also, however, they shown to respond more favorably to the more targeted treatment like ibrutinib versus immunotherapy, chemo immunotherapy. So that's the reason SHM status assessment is crucial for this patient. So why this SHM status is important? So as we all know, the antigen affinity is increased by somatic hypermutation that occurs after B-cell coming into contact with antigen in a post follicular germinal center process. This hypermutation actually introduces by random nucleotide changes into the variable region, which leads to B cell that express immunoglobulin with a high degree of antigen specificity. That is one of the hallmark advantage of its mutated status. Since CLL originated from a single lymphoid cell, each we know that each daughter cell would have with the same IG rearrangement with these mutational changes. So this is really a nice review on nature oncology. So this hypothesis is still kind of disputed at some level, but overall, the idea is many the CLL actually start with hematopoietic stem cells, and then it's just go through after acquiring genetic and epigenetic lesions, as we can see, indicated by some of the arrows here, that is unknown at this time. The cellular output of these lesions could be a polyclonal expansion, and then may lead to a additional antigen stimulation can lead to a more of an oligoclonal selection and expansion of these mature cells. And then an exposure to the antigen, it may go through a post-germinal center processes. So these cells have a CD15 positive and CD27 positive process. And the other side, it may go into it didn't go through that process of expansion, but due to some other unknown reason, that will take a course through other factors which trigger, again, into a monoclonal processes. It could be additional exposure, a T-cell based or microenvironment. You still need to be worked out. And all these additional changes occurred to these processes, it would lead to a CLL, transform to a CLL processes. So again, as you see, the significance of SHM mutated status with additional prognostic factors like favorable cytogenetics or achievement of minimal residual disease negative state after the therapy, excellent outcome following chemoimmunotherapy with the CTR treatment options. So this minimal residual disease detection is one of the other area evolving into a more of a standard of clinical practice. There still need to be some work to be done, while some different situations. I don't have time to go through this, but this is another area actively developing that will eventually help with better disease management. International Working Group of CLL actually issued a guideline for diagnosis and indication of treatment and response assessment and supportive of better management of CLL. Clearly recommend assessing IGHV mutation status prior to treatment initiation in all patients with the CLL, both in general practice and also for a clinical trial. The CLL International Prognostic Index is the most widely used scoring system for managing CLL patients. It's weighted grading of 5 independent prognostic factors. TP53 deletion mutation, together called as TP53 dysfunction, and IGH mutation status, serum beta microglobulin, clinical stage, and age. So this scoring system can help the patient to group into 4 different groups with the different overall survival at 5 years. So the scoring systems are shown here. You can see the TP53 mutation stat deleted or mutated, get a 4, and IGH mutation, if it is unmutated, is a 2, and then other has its own grading, including age. If a patient is more than 65, this grade. 1 grade. And then the risk group is this, 4 different risk group, as I mentioned. Score up to 1 is a low risk, and 2 to 3 intermediate, high with the 4 to 6 grades. And very high risk is if patient with 7 or more grades. And based on this grading, the clinical consequences of the grading can be as shown here. So low risk patient, more than 90% overall survival in 5 years, intermediate roughly 80%, and high risk of 60, and then very high risk patient of 20 plus percentage of overall survival. And then it's also have a treatment indication. Normally low risk patients don't need any treatment, and then intermediate group except disease is really symptomatic, and then other clinical features. They put together clinical features and other factors to decide whether this patient, what level of treatment is required. So as you can see, after the TP53 mutation status, IGH mutation status is the second important factor. And then along with that, European Society of Medical Oncologists actually come up with the guidelines, very recent guidelines. And you can see IGHV unmutated patient with no other features would go with appropriate treatment, targeted treatment, or maybe more combinational therapy. And then if it is patients are IGH mutated, they will be going to chemoimmunotherapy. And then if the patients are unfit for getting treatment, then they are more aggressive combination therapies. So along the line, NCCN guidelines, there's the most recent guidelines. It shows that molecular analysis to detect IGH hypermutation status is one of the crucial status. And it is preferred over other flow cytometry to other surrogate markers. And so assessing the IGH hypermutation status is very important for every CLL patients. And then it's also being used as a prognostic information. As you can see, we went through some of the genetic chromosomal changes, most are unfavorable. And then for the IGH mutation status, if with the mutated status more favorable, and unmutated status unfavorable. And in summary, guidelines clearly say IGH mutation status, especially if you're considering a chemoimmunotherapy, is very important marker for patient management. So that takes us to how we do the laboratory testing for mutation status assessment. As most of you know, the SHM status is defined as if the sequences of the variable region in the patient is different, more than 2% from the germline sequence. And the first European Research Initiative on CLL, or we call ERIC, came up with the initial recommendation for best way to determine SHM status in CLL. It was published in 2007. And subsequently, there is an update started in 2011, how to handle some analytical changes. And the latest one is one in released in 2017. And then, as we know, SHM status, the variable region status, highly restricted repertoire of Ig gene, suggesting again a role for antigen selection in the pathogenesis of the disease. And almost 30% of the patients with CLL, IGHV unmutated CLL also exhibit some stereotypic or quasi-identical B cell receptor sequences. We would go through that in the end of the presentation, to give you a little bit of an idea what's coming up for further analysis. And actually to date, more than 200 different CLL stereotype subset has been identified. This is especially important for unmutated group. And so based on this subtype, we can divide this patient, further stratify this patient with the different biological and clinical features. And so most of you know the structure of the B cell receptors, which is expressed in B cells because of the highly diverse nature of this gene. sequences, you can create a very high number of different combination of the sequences with up to 10 to the power the polymorphic number of cases we can create in a cell is enormous. That is very important for identifying response to different antigens from the cell. So the IGH gene is a pretty complex gene, which is located on the chromosome 14. And actually, once you go through the rearrangement, the process becomes very simple. There are approximately 50 to 60 different functional variable regions, as in the green here, and then roughly 25 also diversifier region and the joining region. Through a very organized fashion, the gene undergoes a rearrangement, which in addition to this rearrangement, there is a random nucleotide additions and or deletions in the diversity and join region, and the VDGA combinations actually result in very high level of diversity. In addition, many of these rearrangements are unsuccessful and do not result in a functional IGA chain due to premature stop codon or frame shift. If the rearrangement is unsuccessful in the one allele, and the cell will go and rearrange the other one, and if it is if that is also unsuccessful, the cell go to the apoptosis. So if it is successful IGH rearrangement is achieved, it will go to the light chain rearrangement and complete the process of creating a functional IGH gene rearrangement. And just to give you an idea, you can see because of the number of polymorphic rearrangements or different variable rearrangement can occur. Each B cell will have a signature combination that is stable through the B cell in normal cases. That we can use to do the assessments and further studies. And as we have seen, why this is very important for the diversity, because this different VDJ combination as well as various pairing of heavy and light chain produces a diverse set of antibodies with the different B cell receptor sequences, and which will allow to identify specific antigen with high affinity. And in addition, somatic hypermutation of the variable region can further enhance that specificity that is very important for the B cell to process. And how we go with the B cell clonality testing. So the first step we actually do to the SHM analysis is to identify the clonal rearrangement in the B cell. So as you can see here, this is a very simple structure of the gene, and there's framework 1 region, framework 2, and the joint region. So we can design the PCR primers targeting this region and then amplify the rearranged sequence to a study. So that brings us to a couple of poll questions here. I'm going to go through before we get into the next stage of the lab analysis. So what method are you currently using for molecular evaluation of CLL? PCR capillary electrophoresis, Sanger sequencing, next generation sequencing, or not? We can go and interested participant can go and answer this. And okay, so we can see more than 60% of the labs are using next generation sequencing. That's great. And so as I was mentioning, there are guidelines that the latest one is published in 2017. Actually, we all follow some of the guidelines so that we can get a more standardized testing, as we know. And then the original guidelines recommend using leader sequences as the from the variable region. The reason is that it can provide longer or full sequences of starting from the joint region. In addition, this the data sequence may have less prone to the other mutation that may affect the binding of the primers at the framework 1 region. So they recommend using mostly linear primers, but use FR1 targeted primers in difficult cases. And we can use the genomic DNA or cDNA as a template. And then after sequence is generated, you can do a sequence analysis using different programs that are widely available. And specimen, you can use standard EDTA to blood or marrow. Then tissue biopsy is also mentioned, but most of us, we either use blood mostly and bone marrow occasionally to do the assessment. Either you can use a cDNA or genomic DNA, and they recommend 5' linear sequences as the starting from the upstream. So the guideline is actually mostly based on Sanger sequencing. So that's why you see some of the gene scan and electrophoresis methodology to analyze. Sequence methodology, both strand using the Sanger sequencing. And then, there is a recommendation of using stereotypic subset identification, but this is still not being a standard of practice in many labs. But it is coming, I think, to a fruition very soon based on new data and research. And reporting the results is, again, the recommendation is based on the methodology I had to mention, and then mutation status is determined only for protective rearrangement because, when we are doing, especially from the genomic DNA, this is a very important factor. If we are from the cDNA, then, we are looking into the expressed rearrangement, so that should not be an issue. But most of the labs are using genomic DNA because of the simplicity to do the testing. And classification is obviously more than 98% is considered as mutated. And there's occasionally you may see some borderline cases between 98 and 97 that can be that's also possible. So we can provide correct interpretation on that. And subset identification, again, is still not a big standard practice. So those initial guidelines, actually, they also went through some of their data for some difficult cases with some frequency as shown here. But this is all based on Sanger sequencing data. But I think with the NGS data, so it's all kind of improved significantly. And again, productive versus non-productive concordant status and double rearrangement, they reported 10%. But with NGS, we are seeing more, more rearrangement. I'll show you some of the examples later on. And then based on the combination, if it is a double rearrangement, we detect based on the status, productive, unproductive, and mutated status, we can provide a correct interpretation. And again, one of the important observations during all these studies has been specifically if the rearrangement is using IGH V321, then this is belonging to stereotype subset 2 now. This shown to be an unfavorable prognosis independent of the IG mutation status. And then as of today, assessment of stereotype is not a routine practice. I'm reporting again with borderline cases for 97 to 97.9 when we had to issue a report following 98% maybe discriminatory between IGH mutated and unmutated cases. So this implication is unclear. But in our experience and most of our experiences, when it's a mutated, we really see a very high percentage. So usually this group is a very small in hundreds of cases what we have seen in our experience. Again, we used to do, most of the labs used to do the PCR Sanger sequencing, where in the leader primer with the joint region is amplified. As you can see here, 2 different reactions. And then you can see the size of the products are analyzed on a gel. And there's a 1 single band on a leader sequence, and same on with the FR1. And we sequence these 2 both products to just identify what is the mutation status. But if you can see, in some cases, you can see a double band, and it becomes very difficult for the Sanger sequencing methodology to identify complete the sequencing. And we had to do gel purification, and it was a very, very involved process. And still, you don't give often good clarity. And then we may end up in seeing a very low level, as you can see here, with the 2 different bands. Then it has been very, very difficult to isolate and sequence. And then you may end up in seeing a smear sort of pattern that is typical of polyclonal. But if you really look closely, there could be a strong band. So the NGS would definitely will help with this kind of situation. I will show you in the later. So what is a different advantage of using Sanger versus NGS for SHM analysis? As you can see here, Sanger sequence relatively cheap, relatively short turnaround time, I would say. But you have a limitation of you can only do a small number of cases in a batch. Interpretation is relatively straightforward, but it's a lot of manual process we had to do unless we can come up with some algorithm. But in versus next generation sequencing nowadays, pretty available in most of the labs. You can even do a very detailed depth analysis, which can lead to even subclonal architecture and interclonal diversity. And then in combination with some other next generation sequencing assays, we can actually batch and then do analysis in a number of cases. We can definitely get NGS completed within a week or so. We have been accomplishing that for a while now. Data interpretation is still a little bit tricky, but I think most of it's getting much better clarity with newly available softwares and other tools, so we can just get them much more easily interpreted as well. So there's an example of here what is the power of NGS next generation sequencing, what we can do. As shown is here, if it is Sanger sequencing based methodology we are using, we would have been missing this smaller subclonal population, which represent roughly 2.54%. But with NGS, you can just get all these very low level clonotypes isolated and sequenced and characterized, so for better interpretation. Then again, if you have a very small population, and we can still miss by Sanger sequencing, but if you use head-up in next generation sequencing, you can just get, as shown here, there's a 2 different clonal population with a smaller population also can be sequenced. In this case, both were mutated. So it helps us to identify the 2 different clonal processes in this patient. So for us, when we are interested in developing a next generation based sequencing for the clonality and also for the SHM status assessment, we had access to the Ion Gene Studio and then Chef prepared system. So they provide us the opportunity to develop these assays in a pretty automated way using combination of the Chef system. But one of the challenges with the ion torrent chemistry that longer fragment cannot be sequenced with high reliability. So we had to go with the FR1 product amplification. And then even though ERIC guideline recommend using leader sequence, so we decided to do a very extensive comparison study with our PCR Sanger sequencing assay. That would lead to another quick poll, what region you use to determine SHM assessment. leader sequence or FR1 or FR1, FR2, FR3 or other. Okay. Yeah, so almost 55% use a leader sequence, and then rest 20% FR1. So what we decided to do was using the IGH assay we have been using for B-cell clonality testing for FR1, FR3 primers, and we also do IG kappa simultaneously, so we can maximize the picking up the B-cell clonality. So genomic DNA as a template primers. So this would allow only amplifying from FR1 and joining region. And after sequencing, we do the genetic IMGG tools. And then, so for the study, the validation study, we use comparing with our PCR assay, which we used to use the leader sequence and FR1, and traditional PCR gel electrophoresis and Sanger sequencing methodology. So again, test principle, as I was mentioning, the IGH assay is targeting a framework region and running through CDR of FR2 and FR3 region. And then the advantage of the test is that it can have up to 12 different indices. So we can, one chip per chip, we can use up to 10 or 10 plus patient specimen during the control. And then we can also batch other T-cell clonality and other assays we have been performing in the lab. So it has been a very good way for us to do all this testing together, and up to 11 specimen per chip. And then we use the LymphoTrack software, which can be used to analyze the data pretty smooth fashion. So an example of the NGS report, as I'm showing here, we start with index, that's the patient identification. Then we start with total count, it's a QC matrix we go through. And we also look at this ratio 1:5, means what's the ratio of the read from the first clonal sequences to the fifth one. So based on our interpretation, we have a ratio of 5 or more than 5 to decide to determine there's a clonal process. So we use that as a way to make sure there's a clonal process in the patient. And then obviously we go for the total unique reads. And then the programs, you can identify the specific sequences. The program actually align the sequences and then merge the sequences with the 1 or 2 base pair differences, and then create a ranking sequences. Then you can identify what are the rearrangement. In this case, as you can see, IDHV3 and 22.1 with the joining region 6 was the clonal product. And then it was 100% matched with the germline sequences. And it was also shown as a protective based on the analysis of the sequences. And then also identify a smaller intraclonal variant in this specimen. But that was also a protective and then matched with the same sequence. So we can also look for what is the V region and J region used in a graphical way if you want. We also will do a separate analysis using IGMT Quest analysis on the web-based analysis. And you can see there is a proof of a productive rearrangement. And then also show you what is the identity with the germline sequences. And it also will provide the additional for the productive, the hallmark sequences for the J region to make sure it's actually productive. And there's another example over here. You can see here there's 2 different clonotypes detected with the total reads of 57 and 5%, and then both were protective. So we can just, and then the analysis showed that they both are mutated. it's pretty straightforward process to identify, but we also will do additional checking to make sure everything is analysis, interpretation is correct. So we compare start with our 49 patient specimen, and 97% of the cases were in agreement with the mutation call, compared with the leader sequence-based PCR assay. And 8 patients actually we couldn't evaluate by PCR Sanger sequencing, but NGS actually help us to actually get a better clear result on those cases. So as you can see, the NGS is definitely improved significantly for interpreting and analyzing the SHM status. And one case we didn't get a PCR product using the NGS assay, and we have concurrent IgG clonality test performed, and it was clonal, so we interpret that as a primer mispriming. So we would arrange to send do a cDNA-based test in another lab to get a result on those cases, and also showed a 41% mutated, 3% borderline mutated, and 43% unmutated cases. And we also looked at 100 consecutive clinically tested cases, and we've shown the same pattern. So interestingly, what we are seeing, we are identifying more biclonal because of the power of the NGS to identify more lower level clonal processes. Overall, the data was concordant with what we are seeing with our initial 50 also cases. But in cases we have a indeterminate status orientational product identified, we would arrange to do a cDNA-based testing to resolve the cases. We have been very, very small number of cases based on so far our experiences. And again, we went back and then did a comparison with another 200 or so cases to make sure what our experience has been the same. So it's all fall into the same. So we probably has to do additional work on maybe 2% of the cases because of different reason. And many of the cases, actually, the patient didn't have enough clonal, there was no clonal basal processes. So that was the issue because many of the cases, they just sent for testing before maybe flow cytometry or other concurrent testing result is unavailable. So when we do it, we will not get a clonal product. So because of, so what we are seeing here, there's a very high concordant result with the FR1 primer agent, but we would do a statement saying that even there's highly concordant with the linear sequence-based assay. So in quick summary, what in our experience has been, even though a recommendation is use a linear sequence to assess the SHM status, using these FR1 region primers, we obtained a very high concordant and quicker results that we can actually do along with our other clonality assays. Also with the automated feature of the ion torrent with the Chef proprietary system, it has been a very straightforward workflow for us to complete this analysis. And actually, there's a study from McClure in I think a few years ago. They found exactly the same as experience as ours. So I just get me the last few minutes, also a couple of slides. So as we can see how the SHM status assessment is evolved over the years, starting with the PCR Sanger sequencing, and then with the now most labs are using the NGS. And if you go back and just look at the evolution of this the observations. And in '99 also, this SHM status with the importance of SHM status in CLL patient has been discovered. And then the importance of the variable region 321 has been discovered around 2000. And then multiple stereotyping of this additional sequence motif similarity has been identified in 2004. And then actually 21% of the CLL cases now belong to serotypes subtypes. And then 30% of CLL may carry overall a serotype B cell receptor G. And actually by 2014, there is more studies showing clinical outcomes with the major subtypes has been discovered. And as you can see here, the subtype actually, how they defined by distinct sequence lengths and motifs within the CDR3 region. So as you can see here, this subset actually dictate prognostic values regardless of the mutation status, at least 4 different subtypes I will show you in the next slide. And actually there are ways you can actually use the sequences to determine these subtypes to serotype this population. And especially with the wide use of next generation sequencing, making it much more streamlined. And as I have shown here, there's 4 different subtypes is shown here, which one type 1 subset 1, 2, and 4, and 8. So subset 1 is actually character utilized different yet very phylogenetically related IGHV genes belong to a certain group and with a specific sequence motifs here. And then the subtype 2 has a different, the use of a very specific group of variable region and diverse region. Based on these sequence motifs and use of the variable region, this has been stratified into 4 different major groups as shown here. And then actually adding into another other genetic features. So you can actually, for example, subset 4 here with a specific group of IGHV 4 to 34 is widely used, and with the deletion 30 is more indolent disease. And then if you go to the subset 2, you see a very aggressive disease progression. And most interestingly, the subset 8, which actually shown to be showing high risk for richer transformation, is very aggressive disease course. And obviously, there are other genetic factors also play into this, in addition to the different serotype, especially the Notch1. But this subtyping, along with other genetic features, there's a very good predictive and other utility for the subtyping features. And then to the new NCCN guidelines, actually just on the draft format right now, but they're recommending to consider in the near future the mutated status, and especially patient with unmutated variable region status and with this subtype information can be used to for a better disease management for the patient. So I just wanted to acknowledge my lab. They're doing fantastic work for all this testing. And also we have an excellent test development team and a direct leadership team which provide guidance for all these studies and validations, and I presented here. And I also thank InvoiceCraft for invitation to present. Thank you.
All right. Thank you very much, Siby, for this really nice presentation. As a quick reminder, if you have a question, please type it into the Q&A panel. And we would also like to ask our attendees to take a brief moment after the webinar has ended to take our exit survey and provide us with your feedback. So with that, let's get straight into the Q&A. Yeah, there's a question about what you do with borderline somatic hypermutation results. How are they generally interpreted by clinicians? Are the patients treated as though they had an unmutated result?
Yeah, that's a good question. I think based on the data, what I have seen, it's still unclear what is exactly the clinical utility for how the clinician is using that information. But as I mentioned, in our practice, these borderline cases are very small, even with, one of the concern, we can think about, doing a FR1 with the joint region. There may be a situation wherein because of the number of sequences we use to make the call, may be contributory to this call. But we did detailed analysis. That was not the case. At least technical terms, I think that was not a concern to us much. But if it is something case, we will send it out to just do a cDNA-based test. Overall, it's a good question. I don't know the answer. But there is an, there is a statement we put to the clinician to be aware.
Okay, thanks. Another question, if you have data from multiple clones and it's not clear, they have different results from those clones. For example, one is mutated and one is not mutated. How do you report a complex case like that?
Yeah, so I think there is guidelines on that as I went through. So, for example, there is a two clonal product. If both unmutated, then it's not be a problem. Or is one is also the productive. First thing is we have to do is whether it's a productive or unproductive. That will give us an idea how can you interpret further. If it's one is productive and then that is unmutated and the other one is unproductive, then it should not be a huge concern. So depending on the pattern we see, we can definitely provide some interpretation. There are guidelines provide some guidelines, but I think that's why it's more important to make sure the productive status. But occasionally we have a situation wherein, very rare, we have a situation wherein both product is showing us difficult to interpret, then we would arrange to send that to a cDNA-based test to just make sure we are calling the patient correctly.
Okay, great. We have a number of technical questions. One is, what is the limit of detection LOD for this?
Yeah, so I think that I mentioned that I think one of the criteria for the clonality assay is we have we validated what is determined to be a clonal. So it is our cutoff is like 5%. With a ratio of the fifth clonotype to the first clonotype ratio has to be more than 5. That's our clonal call. But in the hypermutation analysis, when you see a biclonal, sometimes you will see lower than 5%, but still we will look at the sequence information, and depending on what is the status, we would interpret or provide additional information depending on the status of that specific abundant clone, not the major clone, but maybe a subclone. Okay. But, so overall, our cutoff is 5%.
5%. Okay. Great. Another technical question: do you sequence in both directions, forward and reverse, with this assay?
Yes.
You do. Okay, that was easy. And do you also use this assay for minimal residual disease detection, MRD?
No. That need a very different assay with a very high sensitivity. Okay. So I think that completely different. We don't do that yet. So right now, MRD is mostly in our institution is using flow cytometry, and also occasionally, I think, sending out to a specific lab. They have an assay for a MRD assessment. Okay,
let's see if we can squeeze one more question in. There was a question, I'm just going to read it out to you. When cases are inconclusive due to alignment close to 98%, is a new sample requested, or how is this resolved?
So in that case, we would look into other factors, but occasionally we would send it out to do later sequence-based testing or a cDNA-based test on those cases to make sure we are providing the correct best interpretation as we can. But as again, I think fortunately, these kind of cases are very, very small in our experience.
Mm-hmm. Okay, got it. Yeah, so I'm afraid this is all the time we have today for questions. So with that, let me thank our speaker, Dr. Siby Sebastian, and our sponsor, NVivoScribe. And if we didn't have time to get to your question today, we will try to have someone follow up with you via email.
Sure.
As a reminder, please look out for the survey after you log out to provide us with your feedback. And if you missed any part of this webinar or you would like to listen to it again, a link to an archived version will be emailed to all attendees. So with that, thank you very much for attending this Genome webinar.
Thank you.